Good morning, everyone. Good morning, everyone. Welcome again to the CPNET Health Corner. You're with me, Dr. Chim, Kalumbi, Kambula. I'm your host today. And today we've got a very special guest with us. I know many of you have struggled to understand what is medical ethics all about. And some of you have had dilemmas at your places of work. And maybe you've even been involved in ethical issues or ethical cases that you didn't know how to navigate through. So today we are really blessed and pleased to have a very special guest who's going to take us through medical ethics and the law, and also highlight us, what do we mean by medical ethics? What do we mean by moral obligation? So please stay tuned in, invite a friend to invite a friend. Send our YouTube link so that as many people can join and be educated as well. So I'm going to introduce to you Prof. Edward Konunga. Prof. Edward Konunga has done so many voluntary work in our communities. He's a man who's very passionate to educate the faith communities, to educate the Afro-Caribbean communities and other communities, not only in the UK, but also globally. He has invested so many efforts and so much of voluntary work that he has been involved in many projects. He's also an academician. He is also very good at mentoring. He's also very good at leadership training and coaching. And above all, he's a professor of epidemiology, and he has vast experience in actually on the topic that we're talking about, medical ethics. He's been the lead or the chair of medical ethics committee among 3 trusts within the UK. So please, ladies and gentlemen, welcome Prof. Edward Konunga. Prof, over to you.
Right, thank you, Dr. Chim, for the introduction, and glad to be here to just share a little bit of my experience with the agenda of ethics, and especially as they apply to health professionals. So the way I'm structuring the talk is I'll try to cover a number of things. But the first one, I guess it's for us to be very clear on what do we mean when we talk about ethics. This is mainly because ethics is a word that we tend to use loosely in conversations. And yeah, it would be very good to know what it is and perhaps more importantly, what it's not. Those of you who have done research at any stage will know that if it is research involving patients or people, if it's primary research, then it is subject to ethical approval. So some of you will definitely have had the experience of applying for ethical approval. And in that setting and that context, it is mainly to ensure that the subjects or the participants of a research are not harmed in the process, either by things that the researcher may do, or in some cases, the things that the researcher may not do. So that's ethics that the majority of us will in some way or form recognize. But then you will have had people talk about, oh, this is very unethical when they are describing something. So it's very important that we agree on what the official definition of ethics is, so that we are very clear when we're talking about ethics, what exactly we are talking about. But before doing that, I guess to lay the foundation of the discussion, it's very useful to acknowledge that as individuals, we all have over the years developed a sense of what is right and what is wrong. And that is arrived at and informed by lots and lots of influences, partly to do with how you were brought up. So you do have familial influences in terms of how you decide between what is right and what is wrong. Communities play a role within that. Your faith or lack of faith plays a role also in that. And because I'm talking to Christian Health Professionals Network, I will make reference to the Christian faith, but that's not the only um, player in terms of people's decision on what is right and what is wrong. So we arrive as health professionals with a lot of background and context in terms of what we believe is right and what we believe is wrong. And there will be some things that we hold very, very strong views on whether they are right or wrong. And then there will be some gray areas where there is no absolute answer, but you've got a preference. And then, yeah, you then start your training as a health professional, and you are then subjected to the professional values. So, depending on which profession you sign up to, you will have a set of professional values that govern your practice. So, if you are a doctor, the GMC does have guidance on how to be a good doctor. If you are a nurse, then NMC does have a code of conduct. If an allied health professional, so physio, occupational therapist, there will be within the Healthcare Professions Council that code of conduct. So that then guides your practice, the scope of your practice, what you can do, what you can't do, what is your responsibility as a professional, and how you discharge those responsibilities. So every health professional will have a place that they belong and where they are registered professionally. And I would encourage you, if you are not aware of that, then just go on the website of GMC if you are a doctor, NMC if you're a nurse, and probably nurses and midwives are covered by the same, or if not, then the professional body for midwives would have that. And then for biomedical scientists, physios, OTs, speech and language, go on the Healthcare Professions Council, and you will see the professional code of conduct. And so, as much as possible, abide within that professional code of conduct, unless there is a clear reason for you to deviate from that. And if there is, then document that reason. So we are all expected to keep up-to-date notes about the care we are delivering to patients. And if there is any reason why you cannot maintain that record, then it then needs to be documented, because what I have seen over the years is people ending up in problems or in professional issues because they have deviated from the code of conduct. So whilst that is not about ethics, the reason why I'm bringing all these in is sometimes they are then brought in as ethical issues, when in actual fact it is about professional code of conduct and what you were expected to do that you might not have done, or not done properly as your profession expects. Then above that, we all work for organizations. So your organization will have operating procedures for how to do certain things. They will have delegated responsibilities on what you can and what you cannot do. And it is very important that we understand the scope of our practice within the organization. Because there may be instances where, despite your professional training, despite that you're capable of doing something, if your organization does not give you the authority to do it, then if you go ahead and do it, then you're acting out of the organizational arrangements. So again, it's very, very important for us to be very much aware of what those organizational values are and how they are discharged, because they also guide what we can and what we cannot do within the organization. And a wide range of ethical issues within practice are covered by organizational arrangements. So I have experience of chairing clinical ethics committees for NHS trusts, and we receive referrals from clinicians and managers and staff who say we've got this ethical dilemma. There's no right or wrong answer, but we need some guidance. So I guess the reason why I'm mentioning this is if it's an ethical dilemma that concerns management of a patient, there are within your profession, within your team, ways in which you can seek guidance to resolve that, which might start off with talking to whoever your line manager is, who you report to, or the senior clinician in the team. If you're in an MDT, you can reach out, seek the views of others, peer support, but then also establish if your organization does have a clinical ethics committee, because again, that's their role to provide that advice. So as you can see, there are different layers. Starting off with me as an individual, I've got my own values, informed a lot by my background and who I am outside of work. My religion, my tradition, my culture is part of me, and it will determine what my moral compass is. So my moral compass is not just one thing, it's made by a whole range of different things, and that is morality. Morality is to an extent a subset of ethics, and it speaks a lot to what I think is the right thing to do, or what I think is wrong. And that is what guides us as individuals. But there will come a time where my own morality does not align with what everyone else believes in. And so you'll find later on when I come back to the principles of bioethics that one of the key principles is around respect for autonomy. So you expect to be given respect to make your own choices, make your own decisions, and you've got also the right to believe in whatever you believe in. And so does the next person sat next to you. And so that's where we need to be very, very cautious and very careful that we are not imposing our own moral compass onto others, and in the end up stigmatizing people, and we end up acting out of our own morality, which might violate other people's right to have their own views that might be very, very different from ours. So morality is yes, it does touch on ethics, but not everything that is ethical will align with your own morality, and vice versa. Not everything that society might deem as moral is in line with the ethics principles, and therein lies the challenge in terms of our clinical practice on how do you navigate doing things that are against your very strong belief system, against your very strong thoughts of what you believe is right, and against everything you stand for. Now that brings me to a principle that I will touch on very briefly, but perhaps we can expand on later on, Dr. Chim, which is about moral injury. And moral injury it's a term that we have now adopted within health and care, but actually originally it came from the military. And they describe moral injury as the damage that is done to one's conscience or moral compass when that individual either perpetrates, so they actually do something, or they witness something, or they are seen as having failed to prevent an act that goes against their own moral beliefs, their values, and also their own code of conduct. So you're talking about in the military where your moral compass tells you that it's not right to take human life. However, you are in a war scenario, and you have to win the war. Sadly, blood will have to be spilled. And so moral injury is very well recognized. It's different from PTSD, but it is very well recognized within the military service that there can be a lasting emotional, psychological, social, and behavioral, and in some cases for those people who have got a faith, spiritual impacts of the actions that they've been made to do that are seen to be against what that members' core moral values are, and to an extent behavioral expectations of self and others. I'll come back to that because the pandemic did create a number of moral injurious environments, and some of the decisions and the things that we ended up doing could have led to moral injury. So yeah, I'll bring Dr. Chim there very briefly, but just to sum off the introduction, yeah, we need to consider ourselves. We don't just arrive without a background and a context. A lot of our background and context is influenced by our own personal values, family values, the communities where we come from. In our case, as Christian health professionals, our faith, and but we have to be mindful that cannot be at the expense of what other people may or may not believe. We have to be mindful of our professional obligations in terms of our code of conduct, and we also have to align ourselves with the organizational values, the processes and systems in place if we are to be effective as health professionals. Dr. Chim, I'll pass back to you if there's any clarification points or anything.
Yes, Prof. Thank you so much. What I took down, I like the phrase that you said, not everything that is ethical will align with your morality, and vice versa as well. And just so before we can ask you to clarify about, the key principles of ethics, I just wanted to ask this briefly because one of many of our members, they posted about this question. So if ethically, maybe your moral value, because of your faith and because of your Christian values, you don't participate in termination of pregnancy, but you also have a professional obligation to provide care or information or counseling to women who are undergoing termination of pregnancy. How do you balance this? How do you deal with this dilemma in your professional work?
Great, thanks. So that's a very practical example, which I think will be useful for us to work through the principles of bioethics. But remember, we said that your own beliefs about an issue, in this case, termination of pregnancy, are moral values that you have arrived at from different perspectives. However, as a professional body and as a healthcare worker in an institution, you will have to understand the position that your professional body takes, the position that your organization takes, and align yourself with that. There have been instances and occurrences where individuals feel very, very strongly about something, and they cannot live with themselves if they continue to do that practice. And in that case, people then have to make a decision on whether this is a job I want to be in. Because as long as you are in that job, you have a duty of care, you have a responsibility, and you will have the professional responsibility to provide air service, in this case, termination. And you might hold views around, you might be pro-life, and you will have to then live with how you will deal with the moral compass issue you've got against what is expected of you as a professional. And to an extent, it's not, and this is not about making a judgment from a Christian perspective. This is about making a judgment based on a provision of service perspective. Because where then do we draw the line in terms of our objectivity as health professionals? If we allow, in this case, my personal views to dictate the services that I provide to a patient or to a group of patients. Because once you go into that territory, where do you then stop? If I suddenly wake up with different views around the use of oxygen, for whatever reason, I use that, I exaggerate to make a point. But if I had extreme views, then where then do you stop in terms of the professional values and the professional views? And I think as health professionals, the bit where we can influence is the professional position. We can influence the organizational position, but when you have a patient in front of you, you either have to negotiate what duties you can perform and what you can't, and have it agreed within your team, or accept that as part and parcel of your clinical practice, you will be expected to discharge those duties. Because failure to do that can put you professionally in a very difficult position, where you either deny a patient access to treatment, you are now in breach of your professional conduct. You are in breach of your organizational values. So that's one very good example where you've got moral compass and moral, very strongly held views against the need for you to provide a service, in this case, which will be a termination. And they are very difficult issues. Now, sometimes those issues can be referred on to ethics committees, and there can be ways of working around those, which might be that your employer and your team recognizes that you hold a specific view and a position, and that they are prepared to get a workaround so that your caseload does not include some of those cases that go against your morality. But that will be a decision that the organization will have to make, and make provision for those people who hold that view. But a very, very challenging and very, very difficult one.
Oh, thank you so much, Prof. And we're just going to ask you to clarify a little bit more on the key principles of ethics. Many of us probably were not aware, as you rightly said, the term medical ethics, it's sometimes used loosely. People don't use it in the way that its meaning, that's what it means. So could you just take us through the key principles of medical ethics, please?
Yeah, thanks for that. So having established what ethics is, we probably kind of touch very briefly on what it's not. So it's not about my personal views. It's not about my religious views. It's not about what society believes to be right or wrong. And it's not about how I feel on the day in question. And it is about what are the standards of us establishing what is right or wrong. Now, some of them are more about the ethical obligations. So there are things that are unethical, and they're also not very moral. So some of those obligations govern things like honesty, stealing, things that we all will agree, you know what, this is not right. But there are also specific rights that individuals will have, like the right to life, the right to freedom of speech, the right for them individuals to believe whatever they decide to believe, the right for expression, the freedom of speech, and the right for privacy and confidentiality. So those are rights, and ethics and human rights go very, very, very close together. And we need, again, as Christians, we need to support the preservation of individuals' rights, because if we trample on people's rights, then to an extent, we might get to a point where our own rights to worship are compromised. So the way you do that, there are a number of different frameworks that people use for bioethics. The one we use and commonly use, so there's a UK clinical ethics network. You can go on their website. They've got lots of information. The most common framework that most people use are the 4 principles of biomedical ethics. So it starts off with a respect for autonomy. So when you've got a situation where there is no right or wrong answer, you have to respect people's autonomous right to make their own decisions. Now, when we are running the ethics committees, we often start by asking, do the individuals involved in this case have capacity? So do they have capacity to make a decision? If they have capacity, then they might make the wrong decision. Well, I guess different decision from that which we might make. So the respect for autonomy is very, very important whenever you have got an ethical dilemma. Is you need to give people the right to exercise their autonomy, which in some cases means that they make decisions that we regard as unwise decisions. But we cannot, because we think it's an unwise decision, then move in and violate their right to make decisions. So one of the key areas you consider is, does this individual have capacity to make a decision? So it's not general capacity. Do they have capacity to make this specific decision? And where they have other capacity issues, you cannot then assume that because the individual does not have capacity, that they do not have capacity to make this decision. So the capacity assessment has to be specifically for the decision at hand. Now, in the event that the individual does not have capacity, so you're talking of situations like your withdrawal of life support, as we have seen recently in the press. We're talking about some patients who will have religious reasons why they should not participate in some forms of treatment. The most commonly cited are people who are Christians and are Jehovah's Witnesses who will not receive blood or blood products. So, and the individual might not have capacity. So they have presented in a health facility unconscious, and one of the interventions that's required is to transfuse. The individual does not have capacity, then the next thing will then be either they've got an appointed guardian, or you then have to work in identifying an independent advisor, and your trust will know all about this. So I will not go into too much detail with regards to that. But there are ways for individuals who do not have capacity for them to have additional support to make what most people then refer to as the best interest decision. So what is in the best interest of this individual who does not have capacity to say what is in their best interest? And if they had capacity, they might say what is in my best interest is for you not to provide me with treatment. So when these cases come for the ethics committee, those are some of the things that we then explore. This individual does not have autonomy, does not have capacity. We need to respect their autonomy. We can, in some cases, ask their family, but sometimes families don't always act in the best interest. So that's the whole point of the ethics committee, in order to support you with that.
CPNET, the Christian Healthcare Professionals Network, was formed in June 2021 with the aim of connecting its members to serve all humanity around the world, with love and compassion, advancing healthcare with professional excellence. CPNET UK is open to all Christian healthcare professionals who are registered with a professional regulatory body. Recently, CPNET UK visited Manchester area. Take a look at some of the activities and how Manchester area has embraced the network and is carrying the vision.
Prof, you touched briefly about moral views or versus against, ethical views. Could you just probably expand on that? So at least we have some insight. What do you mean by that? How should we understand that?
Yeah, so again, in line with the principles, so there's 4 principles, and respect for autonomy is the first one. I guess moral, to put it very simply, morality is driven a lot by personal beliefs, although you can have what society agrees to be moral or not. It has got a component of personal values and your personal beliefs. Ethics, on the other hand, are about how do we come up with a solution for a case where there is no right or wrong answer. There is no guidance professionally. There is no guidance organizationally, either because we are seeing this for the first time, or we cannot make a decision on what is the right or the wrong thing to do. So in that case, it is always important for us not to impose our personal values and our personal beliefs onto that situation, because in so doing, you could then be recommending things that are unethical for that case. And that's where, as I said, if it's a clinical situation, that's where they come to the clinical ethics committee. And on our committee, we bring in diversity of thought. So we've got different professional groups. We have got faith representatives. We have got a legal representative. And when that case is discussed, it's looked at from all the different perspectives. And then you come up with a set of guidance and advice that you might recommend. I'll give you one practical example. So we know that as part of the COVID-19 infection prevention control arrangements, we had to insist on people wearing face masks. Now, what if someone comes and they don't want to wear a face mask? So the Coronavirus Act, whilst it detailed the need for us to comply, it did not have sanctions for people who don't comply. So I come into your outpatient's clinic and I don't want to wear a mask. Now, the NHS Constitution says I have got a right to receive treatment. And we know that if you are not wearing a mask and we don't know your COVID status, A, you could bring it on to other vulnerable patients. So we've got a duty of care for other patients. B, we have a duty of care for our staff. And C, we've got a duty of care of the individual themselves whilst they are in our care. So what do we do with such an individual? Or they refuse to do your preoperative screening. They don't believe in COVID. This thing is all made up. This is what did people talk about? The this is made up. It's all irradiation from your 5G phone posts, and actually all this testing. All of you health workers are liars because there's no way you can isolate that. So I come into your unit. I am not getting a test. What are you going to do? Are you going to force me to do that? You are violating you're not respecting my autonomy. I've got a right to believe in what I believe. You might think it's wrong. Well, actually, I think you're wrong. So the respect for autonomy in that case, those cases will then be referred to us. Now, ideally, what we try to do is to preempt, so you're not ending up with a situation where you've got a patient and we running around trying to find the chair of the ethics committee. But what do you do in those situations? You've got a patient who you know has got a right to receive treatment, but also you want to protect others. And so that's what we do, is then to go down the list of those principles and put aside our own. And in fact, when we discuss these issues, we try not to use any labels. So your prejudice in that case might be, well, these are COVID deniers. But that's a value judgment. You are already saying my views in not believing in COVID are inferior to yours. So you have to strip out any potential things that might prejudice you or be seen to be prejudicing you. These are patients who will not comply, and they are not necessarily negative in that way. So you go through respect for autonomy. Do we believe that these patients have got the capacity to be making the decision? And if they've got the capacity, then yes, they might be making an unwise decision. But then we then go to the second principle, which is about beneficence. So beneficence is about what is the benefit of whatever is being proposed. So whether it is a form of surgery or whether it is continuing with life support, what are the benefits? And so you go through those benefits systematically. If we did this, the patient would benefit this way. If we did this, these are the benefits. You stack them up without prejudice or bias. And then you then go on to the third principle, which is non-maleficence. And so all these come from, I think they are Latin words that are embedded in some of the professional standards that we have, which is basically, above all, do no harm. So we have a duty to deliver services, deliver care in a way that does not cause more harm. Now, unfortunately, the treatments that we administer will cause harm. Dr. Chim, when you are doing your cesarean sections, you are doing harm. You are going in there and you're cutting someone's belly. It does have harm. But the reason why we say it is ethical for you to do that is the benefits outweigh the risks. And so professionally, it is accepted that some of these surgeries do have an element of harm. And when you're consenting the patient, you let them know what are some of the associated harms. So when we're working through this in an ethical consideration, we then go through the third principle, which is, what are the harms associated with this? How could we be causing harm in whatever we decide to do? And you usually, if you've got the option of doing the treatment or not doing the treatment, then you do that for both the benefits. So the benefits of us withholding this type of treatment are these: the prognosis is poor, there is no additional benefit. There are costs associated with that. People don't like to talk about costs, but there are costs associated with that. So those will be the benefits, if you like. And then you then go on to the harms. So what are the harms? And you look at the harms to the patient, harms to their family, to their carers, to their caregivers. And then you then weigh the benefits against the harms. And you look at, do we have more benefits? And is there a way of mitigating some of the harms? So again, to use Dr. Chim's example, yes, we know that C-sections will be painful afterwards. So you've got your analgesic pathway, that you will make sure that patients are kept as comfortable so that you're beginning to mitigate and to reduce on some of the harms. Then the fourth principle, then I'll come back to you, Dr. Chim. The fourth principle is about justice. So justice has got so many facets. The first one is justice, which is about no prejudice or bias. So am I only doing this because it is someone I like or I don't like? So I don't like this person because of my own biases, so I will push. But if it was somebody else, then I could have done something differently. Then that way you're violating an ethical principle, which is about a consistent approach that is without prejudice or bias. But then justice is also about distributive justice. We've got a fair limited amount of resources. And so how do we use those resources in a way that perhaps people describe as utilitarian, the greater good for the most people? And you see a lot of this, those of you who have done major incident planning, when you are prioritizing your patients who have been badly injured, and you're having to decide, you are out on the field hospital, and the helicopter can only take 3 people, and you've got 6 people who are badly injured. How do you decide which 3 people get on the helicopter? It can't take 6, otherwise it will crash and it will cause harm to everyone. So what is your decision making on who gets what? Recently, the pandemic, that played out for some of our colleagues in terms of who ends up being passed on to intensive care. They come in with severe COVID and you have to make a decision. And that's where the moral injury comes in. Because the majority of healthcare professionals, we have trained to save lives. But here we are, because of the situation, we can't save everybody. And so you will know there were some people, if it was in normal times, that you could have saved. We will know, and it will come out in the COVID-19 UK response review, when it does go ahead, that there were decisions that were made on who needed to be discharged back to care homes and who would not be admitted to hospitals should they deteriorate. Now, in normal times, that's not your instinct as a health professional. And so that's where the moral injury comes in. And we did a paper where we did a survey of healthcare workers and moral injury. And we found that during the pandemic, people were not too worried about their own actions. Things that they felt they were in control, that's fine. But they were more disturbed by the actions of others. And the actions of others included being redeployed, being asked to do other duties. I'm predominantly orthopedics. For specific reasons, I went into that career exactly knowing what I'm putting myself forward for. And then suddenly I'm being asked to work on a medical ward. That can also be moral. It can invoke moral injury. And then the whole thing of seeing many people dying in huge numbers in a relatively short time, again, could be moral injurious. But the big issue in that situation is limited resources, and you need to distribute those limited resources and make decisions that you know will result in adverse outcomes for others. And how do you arrive at that? And fortunately, which is why I said, for the big ethical dilemmas, you're not on your own. And never feel like you're on your own. Use the team around you. Find out if your trust does have ethics committees, and make the referrals so that it is not your own decision. You are seeking guidance and advice from others.
Oh, thank you so much, Prof. You really highlighted some of the dilemmas that we face as Christian healthcare professionals, and not only for Christian healthcare professionals, but for any healthcare professional in our workplaces. So, Prof, we've got just a list of questions that people wanted to know, and I'm just going to ask some of them. The theme, I think, is the same. They do have similar themes, so I'm just broadly bring these questions to you. So many have asked about, from the nursing point of view, being asked to dispense medications that the patient's doctor has wrongly prescribed. How, if they find themselves in a court case or in a disciplinary action, how do they navigate the situation whereby they're being asked to dispense medication which the doctor has prescribed wrongly to the patient?
Yeah, so that's an interesting one. And again, I don't think it's an ethical dilemma. Just to put that right, I think it's a quality of care issue. It's an issue to do with how do we avoid passing on defects. So at some point in my career, I did the Toyota production system quality management arrangement, and I had the opportunity to go and observe a hospital in the US that was working on Toyota production system arrangements. And one of the things that Toyota in the car manufacturing industry talks a lot about is empowering every worker with the ability to stop the line. So the stop the line approach is, we are working on a conveyor belt. My job is to fit wheels, but actually I noticed the guy before me who's supposed to fit the doors has fitted the door wrongly. I am empowered to stop the line. And when I stop the line, we then find out where is the problem, and the problem is sorted at source rather than I just do my job and pass it on. So the reason why I use that analogy is, if you observe that there is a mistake that could compromise patient safety and patient outcomes, you have a duty of care to raise that with the appropriate professional, to discuss, to say, look, the dosage that you have put down for this patient seems to be very, very high. And the professional might have a reason for doing that. So yeah, let's have a conversation. Why is this patient on double the dose that we normally give? And an explanation is provided. You document that I noticed that the medication was double the recommended dose, but on clarifying with Dr. Chim, she provided me with the rationale for that. Document, because some of these cases are then looked at retrospectively. And if it does come across that you had seen it and went ahead and dispensed without clarifying and checking, then that is clinical negligence. So we have seen a lot of this, and I'm glad that Dr. Chim might be able to build on that in terms of the World Health Organization surgical checklist. So I'm there, I'm the scrub nurse, or even more so, I am a student. I'm a student nurse, I'm observing surgery being done on a patient, and I notice that there is a swab that has not been taken out. And I then keep quiet because I'm scared of, I'm just a student nurse. Actually, that is clinical negligence. So the team needs to create an environment that enables everyone to take responsibility for the quality of care for the patient. And that when they seek clarification, that is not taken up against them, but actually that is encouraged. Oh, that's good that you've asked, because in some cases we would have passed on a defect. And the Toyota production system talks about, we don't want the defect to be noticed by the customer when it has passed 5 or 6 of our people. So yeah, I would say that's not an ethical dilemma. That is a clarification your duty of care. As a team, gone are the days when the surgeon would say, what are you doing with my patient? The patient does not belong to the surgeon, does not belong to the consultant. It is our patient, and we all collectively have a duty of care towards that patient. If it was you, and you knew that what has ended up affecting your loved one, resulting them having complications, and in some cases losing their life, was because a certain health professional felt that they could not challenge, how would you feel? So yeah, that's not an ethical issue. For me, that is more duty of care and how we decide those duties as part of our clinical services.
Yeah. Thank you so much, Prof. I'm conscious of our time, but there is a very interesting question as well. This is to do with one of the nurses who has asked, if I'm struck off as a nurse by my current regulatory body, and my current registration is struck off on the list, can I go back to retrain as a nurse in order to get re-registration again?
I guess I'm probably not the best person to give advice on that, but professional bodies will have standards. And for me, that's more about our own values. So if you are asked, have you ever been struck off when you're trying to do something? Are you prepared to disclose it, or will you just not mention it? An example is I get struck off here, I jump on a plane, and I land there and I register over there and I start practicing. Is that ethical? Of course it's not. Is that moral even, before we've even gone there? It isn't. I mean, one of the things I didn't talk about is what's referred to as the Nolan principles of public life. And yeah, I would encourage you to just look them up. They are things that are expected of us as we work in public office. They're supposed to apply to everyone, including politicians and everyone. But I'll leave you to make a decision on whether our current politicians are sticking to the Nolan principles. But the 7 Nolan principles are about everything we do should be from a selfless point of view. So we should not manipulate the situation to gain personal benefit out of people suffering. Integrity, we need to have integrity and be true to ourselves. We need to be objective. We need to be accountable. Stand up and be counted. Own up if there are mistakes that you have made. Don't try and cover it up. Openness, so we need to be transparent and share whatever information we have within reason, obviously, in line with organizational principles. So I'm not suggesting you are open enough to go to the sun and you talk about things happening in your organization without following the appropriate channels. Honesty and being very good leaders. So those are principles of public life that I'm sure most of us who are practicing Christians will inevitably find that they are biblical as well. So I guess there are some things that are not ethical dilemmas, and what I've tried to cover today is where you've got a true ethical dilemma. What are the arrangements that are in place within your team, within your organization? What are the key principles that you can apply yourself in terms of coming up to a decision for an issue where there is no right or wrong answer? But then the other issues that we face in our professional practice, they are not necessarily ethical issues. There might be moral issues, which then have to speak to your own personal values and how you are going to deal with that. Or there might be professional conduct issues, which again, there's a separate arrangement that deals with those.
Thank you so much, Prof. And Prof, just for the benefit of our listeners and our viewers online, please, can you just maybe highlight a few resource areas whereby people can go in order to, to get more information on medical ethics and law?
Yeah, no, thanks. So there are a number of resources that are available. So There's a UK Clinical Ethics Network. So their website is www.ukcen.net. And on there, they've got lots and lots of resources, the different frameworks. I've only talked about one, which is the most popular one, but there are other frameworks as well. So that's one place. The second one, I would say within your organization, there will be some form of arrangement for consideration of ethics. So again, try and find out within your organization, how do we deal with ethical issues? It might be that you don't have a committee, but actually you can use those more senior than you to get their opinion and to get their views. Then every professional body, certainly during COVID-19 pandemic, the first few waves, I know the BMA had a big section on ethics as they relate to COVID-19. I know the Royal College of Psychiatry had that, and other professional bodies will have a section around ethical dilemmas within your specific profession and within your specialty. Above all, if you are in doubt, then ask and don't think you can make a decision, because I often say don't use your common sense when you've got an ethical dilemma, because the moment you start using your common sense, you are now applying your own values and your own morality to an issue, and that does not stand up when challenged. So you need to take off what would I do in this situation and talk your way through those 4 principles. And we document. The reason why we're giving this advice is we consider respect for autonomy, and we came to this conclusion. We weighed up the benefits of the treatment against the benefits of not giving the treatment. We looked at the harms of the treatment against the harms of not giving the treatment. And then we asked ourselves, if this was somebody else, would we be making the same recommendation? And so our recommendation in this scenario is this. So that's what the benefit of an ethics committee would give you, is that you'll have people looking at this from different perspectives, and it avoids you making a common sense decision or what feels right to you, because when challenged, you will not have a leg to stand on.
Oh, Prof, thank you so much. I'm sure we all have learned quite a lot, and we've got a lot to reflect on. And one of the things that you said actually is, as Christian healthcare professionals, we are called to work with integrity, to work with honesty, to work with transparency, and also, to work with kindness and love, and also to be supportive to our patients and to give all that we can do and all that we can give to our patients with all our heart and with everything else that is in us. So it just shows us that, it's important as Christian healthcare professionals for people to see the light of God in us, in our duties, in the way how we do things. And when we come across all these ethical dilemmas or challenges at our places of work, you have rightly said it's important, ask for help. Be familiar with the protocols that are in place at your governing bodies, at your places of work. And also read. Many of us, we don't read. It's only when a problem comes our way, that's when we say, oh, I don't know about this. Be familiar with all your policies, all your protocols. Be familiar what is required of you with your regulatory bodies and what is acceptable, what is not acceptable, so that you know how to operate within the parameters of your profession. So, Prof, many thanks. It's been a privilege to have you on our program, and we just want to say thank you. And to our listeners and to our viewers, we just want to thank you so much for sparing your time to tune in with us. And please do subscribe to our YouTube channel so that, set up reminders so that you don't miss out our monthly Health Corner programs. Thank you. Bye-bye.